Okay. Talking about two diseases of the ramification flora. First one is about these both relate to chest trauma, so just talking about the incidence of chest trauma, which is pretty severe, pretty high mortality rate, and a significant number of people with chest traumas do develop pneumothorax as they go along. If you think about it, with a deceleration injury, when the chest wall hits the steering wheel or whatever other portion is there, you can end up having the ribs themselves breaking, and the tissue below your lungs themselves, just like any other tissue, if it gets bruised, if you will, there's a lung contusion that can exist from that. And a lot of times just monitoring these patients, there's not a lot we can end up doing for them, but just making sure that they remain stable for that period of time until they're it's resolved, because a lot of them can develop ARDS secondary to it. All right, flail chest, by definition, is a double fracture, so 2 points of fracture on a given rib, and 3 or more adjacent ribs. So what you end up having is, instead of having this nice stable chest wall, you have a pocket of it where the ribs are broken. In 2 places, 3 or more consecutive ribs. 2 places on each rib. So this is the picture that you would end up having. Okay? Multiple ribs, multiple breaks on a given rib. Okay, 3 or more. The problem is that the chest wall then moves opposite of what the rest of the chest wall moves. On inspiration, instead of there being the chest wall moving outward, it moves inward over that flail. That means that that portion of the lung below the flail is not being adequately ventilated and can end up developing a pneumonia in that area, along with the contusion of the lungs secondary to the fractured ribs. You think of automobile accidents probably being the more common one, but industrial accidents, being caught in the press, falling into a combine, kind of weird stuff can happen. Compressed by a heavy object. Sports technically can be, yeah. You don't see it that often, but yeah. Football, curling. They'll do what is called pendulum respirations, where basically on inspiration you have gas going into the unaffected side, and on exhalation it moves from the unaffected side to the affected side. So they basically are just rebreathing some of this gas and process, which is going to not be effective valvular ventilation in essence. So here I have my flail on the right-hand side. As we take a breath in, nothing is inflated on the right side, but the left side is inflated because that is not damaged. When the patient exhales, some of the exhaled gas goes back out, but some of the exhaled gas goes back into the poor lung. Okay? So this lung then is, if it's being inflated at all, is being inflated with gas that already has a high CO2 content in it. So it's not going to be an effective mechanism. PCO2 can go up on these folks, yeah. So you end up having massive atelectasis, will lead to shunting, and you end up having hypoxemia secondary to that. That hypoxemia and perhaps a subsequent hypercarbia that develops is going to stimulate those peripheral chemoreceptors, aortic bodies, carotid bodies, to stimulate the patient to ventilate faster. Let's see if I can get this to work. You see it? That's a flail. Negative intrathoracic pressure is pulling those ribs inward. Say again? Somebody have fractured a rib in here? Hurts like hell. Well, if he ain't, he's going to be in a short time, yeah. So these patients typically are stressed, as you might imagine. The degree to which the blood pressure change and the cardiac output changes also depends upon volume loss. So assuming that there's not any hypovolemia present or preload down, you'll get that kind of a response. But it's the paradoxical movement of the chest wall that is key.
Now, they would put somebody with a test to that day.
Through what?
Pulmonary function testing?
No.
Oh, good.
But what happens to pulmonary function? It all goes down. It's a restricted disease process. That's the way we're going to classify it. Okay. No, we would never get it. Blood gases, initially you might just see if it's a small on a flail, a respiratory secondary to hypoxemia that's present. And as we were mentioning, as the flail becomes larger or the patient becomes fatigued, you end up having a frank ventilatory failure happening where CO2 rises in addition to the O2 falling. Over time, the reduction in PaO2 will lead to lactic acid acidosis developing and a superimposed metabolic acidosis along with the respiratory acidosis. Mess. Because I don't have adequate oxygen delivery to the tissue. So if they happen to have, if their blood pressure is low, maybe because they lost blood, now I end up having both present. Usually not surgically. You just tape them and wait for them to naturally heal. No, I haven't seen that done. On chest X-ray, you'll end up seeing of atelectasis along with rib fractures, and they're prone to pneumothoraces, as we'll see. Basically, analgesic to treat pain and looking at being able to mobilize secretions as best we can. One of the things that we can do is paralyze them if it's significant enough, and basically ventilate them and control their respiratory efforts by paralyzing them, as I said. Use of PEEP sometimes helps too, the idea being that it splints it back outwards, and
Rick, the picture that you showed, would you classify him as severe?
yeah.
Okay.
Yeah.
Good, because I'm glad that wasn't mine.
Okay, so pneumothorax. What about that entity? Again, it's the accumulation of air in the intrapleural space that causes the parietal and visceral pleura to separate. Anything, if you remember, when you have a pneumothorax, the tendency of the lung itself is to collapse inward, and the chest wall to move outward, and you end up basically having a situation where that shift in the lung can actually cause the great veins to be compressed and preload to be reduced secondary to that. So here's the pneumothorax where I have air in the intrapleural space instead of that membranes being right next to each other, the visceral and parietal pleura being next to each other.
So the tracheal shift is away?
Tracheal shift is away from the site, yes. I don't know how well you can make this out, but there is a vertical line that is right here. You see the arrows? It's right up to the arrow. But this is all vascular. You can see there's no vasculature here where you can see it elsewhere throughout the lung. So this is basically just a large pneumothorax, air in the intrapleural space. On a CT scan, it's pretty easy to recognize also because you have that air compressing and it looks like it's shifting stuff over to the opposite side. Really hard to pick up in the ICU, primarily because your quality of film is drastically reduced. It's also an AP look rather than a PA look, so it's not as good. Using what is called an expiratory film, where we basically have the film, the X-ray taken at exhalation and at inhalation, can be pick up pneumothoraces a little bit easier. 3 ways for gas to enter. The 2 of them are pretty obvious. One, you can get a tear in the visceral pleura from the inside out,
from the inside into the pleural space. You can get one from the outside through into the pleural space, so a puncture wound. And the last one is that you can get a empyema, which is a collection of pus within the pleural space, that pus basically producing a gas as part of its metabolic activity, and you end up having gas collection in the interpleural space. It's some really bizarre anaerobic infections that would lead to that kind of a concept. Can be traumatic in nature. I always think of the movie Backdraft, where Robert De Niro gets blasted back and ends up on the spike in the fence. You got a problem here. You got a pneumothorax. Spontaneous pneumothorax, ones that are basically where, for whatever reason, the patient's lungs are weak, and there's a tear that is created in the visceral pleura. In iatrogenic, again, if you don't know what that term means, it means produced by us, in essence. So a pneumothorax that occurs secondary to some procedure that is going on. Okay, starting a subclavian vein, cannulation, and nicking the apex of the lung and causing the lung to collapse. Again, any kind of a penetrating wound would cause that traumatic pneumothorax, where the parietal pleura would be opened and air can enter in from the outside. Spontaneous, usually, again, they occur with no obvious reason. See it a lot in tall, thin people, especially tall, thin athletes. But you can also see it in patients who have underlying lung disease, and we see it, as we'll find when we talk about newborns. Quite often that first breath can end up having a pneumothorax developing along with it. One special type, ladies, catamenial pneumothorax is a pneumothorax that is associated with menstruation. And basically it has to do with the endometrium sloughing, which normally does during that time. That tissue is exactly the same thing what happens in the pleural space, and you end up having that tissue lock the sheds, literally. And get a young woman in who's complaining of pneumothorax, questioning the time of month and the presence of menses, and we end up getting a correlation there with them. That I don't know. Cause. If this was on the left, it wouldn't be. You get talked about iatrogenic, all kind of different things they can end up having. Mechanical ventilation can have, as a consequence of it, a pneumothorax developing, especially when we're using excessive ventilating pressures. As we add PEEP to the circuit, take back here, remember that as you raise the floor, you raise the peak pressure also, and that puts you more of a chance of developing.
Violation of someone that has pneumothorax to use smaller volumes and high rates?
Not necessarily because they got a chest tube in. You should ventilate somebody who doesn't have chest tube in place. Untreated pneumothorax is a contraindication to all positive ventilation. Typically, it doesn't matter at that point in time. The exception to that is that last bullet point, which talks about if I have a situation where I actually have a bronchopleural fistula, a connection that exists between one of the larger bronchi and the pleural space. What ends up happening, you have a chest tube in place, obviously because the lung had collapsed. What ends up happening is they put gas in, it goes out through the chest tube. So it really complicates because I'm not effectively ventilating that. So at that point, you need to have that, you need to adjust the delivered tidal volume to account for some that is being leaking out the chest tube. Open pneumothorax is one where the gas can move easily in and out of the pleural space. Closed pneumothorax is one that's valvular in nature, and that air can come in, but air cannot get back out of that pleural space, and that's where you end up having a tension developing.
Okay. So here's a sucking chest wound where it's an opening between the parietal and the visceral pleura, where the visceral pleura is intact but the parietal is damaged. Air can get in, and on exhalation, air can actually get back out again. So what we want to try to do for that is to create a one-way valve. So here I have a dressing that prevents air from entering in but allows for air to exit back out through an opening. Okay. On the valvular side is one where you end up having the visceral pleura torn, and that's where air can't get in and out. It can leak into the intrapleural space, but there's no place for it to go at that point, and that's where you start seeing the tension developing. And we identify that by looking for mediastinal shift, alteration in the point of maximal impulse, if you were to listen, tracheal shift, looking at the substernal point for shifting of it, and these are the ones that can rapidly deteriorate into cardiac arrest as that tension becomes larger and larger and pushing and twisting the great vessels, you end up having cardiac output being eliminated. Okay. That's that valvular mechanism. This is showing from the outside, but it's the same exact problem that it can't get back out again, so that tension can develop. There's tracheal shift. You can see pretty predominantly huge right-sided pneumothorax pushing everything over. And this is just a collection of air. The air typically will collect at the top. Blood and other stuff will collect at the bases. And there's an example of hemothorax. So, patient's going to be in distress, obviously. It's not something where the chest pain they have is associated with breathing. So they'll tell you that it hurts more to take a breath in, and they may develop the presence, especially in mechanically ventilated patients, of the subcutaneous emphysema, which is air collecting in the subcutaneous spaces. And here's a little guy who has a pretty significant subcutaneous emphysema all up under his skin. And if you were to touch the skin, it feels like a little bubble wrap. You know, it's the eeriest Has somebody had felt it?
I felt it.
Yeah, just gives me willies. And this is what it will look like on a chest X-ray. You can see all the subcutaneous air. That funny looking fluffiness that is there outside the chest wall. So this is basically a collection of air in the subcutaneous tissue. Resolves naturally over time. Nothing much you can do about it beyond that. Just wait for it to be reabsorbed and to go down.
How long does it take for it to reabsorb?
A couple days. Here you can see it again on a CT scan. Here's my rib cage. Here's the outside of the chest wall. You can see the collection of subcutaneous air. So we want to identify any mediastinal shift that may be present. And again, it's going to be shifting it away from the affected side. If we did diagnostic percussion, they would have a hyperresonant sound over that area, and obviously the breath sound would be diminished. Okay. And if you were to look at their chest, they wouldn't have a symmetrical chest, at least in theory. And not necessarily true, but they talk about hyperresonant sound due to track gas. And because of the no airspace going there, there's a reduction of breath sounds. Again, try to look for an expiratory film to be able, and compare it with the inspiratory film to pick up on it. Look for loss of vascular markings. Sometimes in the attention using mediastinal shift. And atelectasis is present, obviously.
Just in pneumos in general. Something called an occult pneumothorax, or ones that aren't picked up on chest x-rays. They're usually very small and don't require any kind of intervention. They'll resolve on their own. And we talked about subcutaneous emphysema, how we pick that up in the soft tissue. The hypoxemia that present in a small pneumothorax may just lead to some alveolar hyperventilation as a compensatory mechanism. If it's large enough, as you would imagine, there's ventilatory failure that exists. And again, secondary to that, the metabolic acidemia developing from the lactic acid in the presence of a hypoxemic patient, the reduction of cardiac output is pretty well assured. And no, we don't do pulmonary functions on these people, but as you can imagine, if you were to, you would find all their volumes reduced. Again, restricted disease process. With neonates, because of the very thin frame we're dealing with here, there actually is what is called transillumination, where we can hold a light up and identify where the lung is not being inflated. Because they're so small, it works out just fine. It's kind of like putting a flashlight on their back. Small pneumothoraces usually is consistent 20%, and that's ones that we basically don't do much about, just allow the reabsorption to happen. Perhaps you can do some needle aspiration, but for the most part, those are just left to manage on their own. Larger pneumothoraces and those that are under tension for sure need to have needle aspiration and a chest tube placed. And the chest tube is placed to an underwater seal or some sort of a mechanism where air can't enter back in again. Okay. Persistent spontaneous pneumothoraces will have a procedure called a pleurodesis. And the pleurodesis is where they put a chemical compound actually into the interpleural space to make it irritated with the hopes of it sticking together. Okay, they can use talc, they can use some antibiotics. And that's reserved for those patients that have just recurrent spontaneous pneumothoraces. Pretty obvious. This is what the Heimlich valve looks like. If you can imagine a latex glove, disposable glove, and you cut off the finger and you make cuts on either end so that it's able to have air go out, but you can't get air back in again. Okay, it's called a Heimlich valve, and yes, it is the same Heimlich. But this is as the patient exhales, they can exhale back out through that. But when they take a breath in, this doesn't allow air to pass the opposite direction. It's a one-way valve. And once we get the lung re-expanded, with the chest tube, we're going to go ahead and evaluate that, and they're typically clamped for about a day to make sure it stays inflated before they remove the chest tube. That's the pleurodesis I was talking about. Chemical sclerosis is what you end up doing. Inserting of a chest tube, we always want to insert on the, we're not going to do this, but for tension pneumonia, doing needle aspiration certainly is within the scope. But you want to go on the superior surface rather than the inferior, because that's where the location of the nerve arteries and veins are. A chest tube system, we talk about having bottles. They're not really bottles anymore. It's all a plastic chamber. But it has three distinct components to it that I want you to know about. First of all, there's a collection system, a collection bottle. And a collection bottle, as the name implies, collects fluid. So if somebody comes back from open heart surgery, we know their mediastinum, we know their interpleural space is going to have blood in it. We got to drain that off, and that's what the purpose of this is. It's going to collect excess fluid that is in the pleural space. The second bottle, the middle bottle, is called a water seal bottle. And this is one where when the patient creates a, let me do this. What color do I have this? Here's my patient. All right? Chest tubes hooked up to them.
You don't know that.
He's on drugs.
That's right. As he create a negative intrathoracic pressure, this is negative, and this is below the surface of the water. So any negative pressure that would be inside this tube would just pull the water back up. When they exhale and create a positive intrathoracic pressure, it'll actually push air back out and push the bubbles, and you'll see bubbles there.
So
Okay?
negative on inspiration, positive.
That's what we normally do, right? The intrapleural pressure is negative, so it's going to go ahead and not allow air to be sucked back into the system. That's the purpose of a water seal. Okay. And the third bottle is the suction control bottle, and this is basically in line with this bottle. And as I attach vacuum here, the degree to which all of this is exposed to a vacuum pressure is dictated by how deep this one is below the surface of the water. So if this is 10 centimeters of water below the surface, the maximum vacuum pressure, no matter what I set this at, I can set this in minus 80, the max vacuum that would be in the system is dictated by that. Okay. Suction control, that's all you need to know now. Control, collection, and water fuel. They go in this order. Okay, we don't use bottles anymore. We use something like this. But it's exactly the same thing. I have a collection chamber, I have a water seal chamber, and I have a suction control chamber. And those are the mechanisms by which we keep the intrapleural pressure. We reinforce by reestablishing intact pleural space. We talked about a bronchopleural fistula where it's a direct action. So any air that goes in goes right through the chest tube, comes back out again. And you'll see a huge amount of bowling involved when that's the case. And sometimes we need to have two test tubes. Sometimes we need actually 3 test tubes. One for the right one, one for the left lung, and the mediastinal space. There is the ability, I think I talked about this previously, but there is the ability to use a specialized endotracheal tube and go ahead and ventilate each lung independently. If one lung has just got this huge bronchopleural fistula, screw it, just ventilate the other lung, put it on, do whatever with it. But more often than not, we'll try to look at some other options that are out there. You can go in and surgically close it, but then it opens up all kinds of other risks, which are best to not have to go back in again. Okay.